Hello, I'm Ian Paul, and this is the fifth module in the series on mood disorders. It provides an overview of the treatment modalities for depressive disorders. In addition to an overview of the available pharmacotherapeutics, it will also describe psychotherapeutic and somatic therapeutic approaches for symptom relief. This module has three objectives. After finishing it, you should be able to list the classes of pharmacotherapies for depressive disorders, describe the major psychotherapeutic approaches to these disorders, and finally, to describe the somatic treatments available for relief of symptoms. The treatment modalities for depressive disorders are remarkably varied. In addition to multiple types of pharmacotherapies, there are evidence-based and validated psychotherapies, social interventions, as well as several highly effective somatic interventions. The choice of therapy or therapies depends on a number of factors, including the severity of the patient's symptoms and/or suicidality, the efficacy of the treatments, their safety, tolerability, and simplicity of use. Finally, especially in an area with high levels of underinsured and uninsured patients, cost should be a consideration, especially since patients require extended treatment to remission of symptoms, and in some cases may require lifetime maintenance. First-line medical treatment for depressive disorders utilizes a range of medications. Here, I'll only describe the general classes of medications available. Other modules will discuss specific medications, mechanisms of action, and pharmacokinetics. The selective serotonin reuptake inhibitors, or SSRIs, such as fluoxetine, are generally the first line due to their efficacy and wide therapeutic index. These are closely followed by the serotonin norepinephrine reuptake inhibitors, the SNRIs, such as duloxetine, which also have good efficacy and therapeutic index. In addition, they tend to be a bit more psychomotor activating, so they're particularly useful in patients whose depression includes psychomotor retardation. The atypical antidepressants include compounds with diverse mechanisms such as bupropion and mirtazapine. Some, like bupropion, are more often used as adjuncts to SSRI or SNRI treatment. The mood stabilizers and antipsychotics are normally used adjunctively with first-line antidepressants. The tricyclics and monoamine oxidase inhibitors are much less commonly used due to low tolerability due to side effects and high potential for toxicity. Recently, esketamine, the S-isomer of ketamine, has been approved for treatment-resistant depression or depression accompanied by suicidality, while brexanolone has been approved specifically for peripartum depression. Both have mechanisms of action distinct from all previous antidepressants, are highly efficacious, and much more rapid-acting than other classes of antidepressant. Most pharmacotherapies require 3 to 6 weeks at an adequate dose before patients report improvement. However, because vegetative symptoms such as loss of appetite or sleep disturbance tend to improve first, family may report improvement earlier than the patient. The cognitive symptoms tend to take longer to improve, in part because they are influenced by other symptoms such as anhedonia or feelings of worthlessness. It's important to treat to an adequate dose. This essentially means titrating patients either to remission, to the maximum recommended dose, or the maximum tolerated by the patient. And remember that improvement is not the goal of treatment. Remission of symptoms is. If there's no improvement at an adequate dose for 4 weeks, consider either an adjunct or a different antidepressant. Remember that many patients with depression have been suffering the fallout of their symptoms, such as strained interpersonal relationships and problems on the job, for months, so it's important to address the biopsychosocial needs of your patient during treatment. Whenever possible, consider including psychotherapy because the combination of psychotherapy and pharmacotherapy is usually greatly superior to either alone. In addition, particularly after the COVID-19 pandemic, Affordable psychotherapy via telehealth is widely available. Finally, once a patient has reached remission, it's important to continue treatment for an extended period. Generally, 6 to 12 months of continuous treatment is recommended after the first episode and longer after subsequent bouts of depression. Some antidepressants have serious interactions, such as those of the MAOIs and sources of tyramine, but remember that most antidepressants are cleared via the cytochrome P450s, especially the 2D6 isoform, so significant drug-drug interactions are common. Be sure to double-check for these against the patient's current medication regimen. Remember that the most serious side effect of most antidepressants is serotonin syndrome. While this is usually associated with high doses or overdoses of drugs like the SSRIs, it can occur at lower doses, especially if the patient's ability to metabolize and clear the drugs is impaired. Be sure to make your patient aware of the early signs of serotonin syndrome, such as agitation, excessive perspiration, and muscle rigidity, because severe symptoms are life-threatening with fevers in excess of 40 degrees Celsius, seizures, and cardiac arrhythmias. In addition to the pharmacotherapies, there are a number of psychotherapeutic interventions that have been shown to be very efficacious in randomized controlled trials. The most commonly used of these is cognitive behavior therapy, which involves restructuring the cycle of thoughts to emotions to behavior and back. Another frequently employed psychotherapy is interpersonal therapy, which focuses on 4 major problem areas: grief over loss, interpersonal disputes, role transitions, and interpersonal skill deficits that are often significantly affected in depressive disorders. Behavioral activation focuses on behaviors rather than cognitions or emotions, and involves working to reduce avoidant behaviors that tend to accompany depression and result in diminished positively reinforcing activities. For milder forms of depression or for patients uninterested in more intensive psychotherapies, supportive psychotherapy involves primarily listening and empathizing with the patient and can provide some relief. But to reiterate, combining psychotherapy with pharmacotherapy is much more effective at relieving depression than either treatment alone. The 2 most common somatic therapies for major depressive disorder are electroconvulsive therapy, or ECT, and transcranial magnetic stimulation, or TMS. ECT is actually the oldest true antidepressant and was first introduced in 1938. While early ECT was a pretty crude technique, it's been greatly refined for safety and tolerability over the years. While its mechanism of action is still unclear, it is currently the treatment of choice for treatment-resistant depression, which is defined as failure to respond or inability to tolerate 2 adequate psychopharmacotherapeutic trials. It's also the treatment of choice for individuals such as the elderly who may not tolerate pharmacotherapies, either due to their physical health or interactions with other medications. And similarly, ECT is often indicated for severely depressed pregnant women to avoid complicating pregnancy or any risk to the fetus due to high drug doses. In all cases, ECT is highly efficacious, with response rates exceeding 80% and response times typically much shorter than drug therapies. In addition, ECT is an effective treatment for catatonia and some psychotic episodes. Modern ECT is administered in a clinical setting under anesthesia with muscle relaxants or paralytics and hyperoxygenation. Normally, a brief unilateral pulse is administered to achieve a seizure as monitored by EEG 3 times a week with 24 hours between treatments. On average, 9 to 12 treatments are used to achieve maximum symptom relief, although therapeutic improvement is often seen within the first week. Responsive patients often receive maintenance treatment once or twice a month. Common side effects of ECT include headache and nausea, which are treated with over-the-counter medications. Cognitive effects are less common with modern ECT than earlier protocols, but patients commonly experience acute confusion and anterograde amnesia. Retrograde amnesia is less common but does occur. Most side effects resolve with time, although there are some patients who have persistent, usually minor memory problems. A more recently developed treatment is transcranial magnetic stimulation, or TMS. This technique uses small electromagnetic coils about the strength of a typical MRI placed on or near the scalp, usually over the left prefrontal cortex. By rapidly alternating the polarity of the magnetic coils, a small current is generated in the cortex by induction. Treatment is typically about 3,000 pulses per day, applied daily for 4 to 6 weeks. Although data are still being gathered, TMS seems to be most effective in mild to moderate depression. Side effects are normally mild, however, rare seizure induction has been reported. Be sure to review the modules on antidepressant pharmacotherapies and, if needed, the module on evidence-based psychotherapies. You can also find more in-depth discussion of ECT and TMS on UpToDate.